everyone, and welcome back to ASA Live. My name is Dee Goldstein, and I'm the Senior Manager of Revenue Growth Strategy at the American Society on Aging. Today, we embark on part 2 of our series on living and dying with dementia, where we'll be talking about what to expect with late-stage dementia. If you haven't seen part 1 yet, we'll have a link posted in the comments, and I really encourage you to watch it. As a reminder, if you have any questions or would like to join the conversation, please do so in the comments section. Our guests will be answering questions throughout our conversation and at the end. And once again, I am joined by Compassion and Choices National Director of Clinical Engagement and Education, Jessica Empeño, and America's Psychologist, Dr. Jeff Gardier. Jessica, Dr. Jeff, welcome.
Hello there. Great to be with you.
Glad to be back.
Now, in last week's conversation, we talked about dementia as a terminal illness, as well as some of the signs and symptoms of this disease. Dementia is often described in stages. Can you talk a little bit more about what that means?
Dr. Jeff, you want to start?
Sure, why not? Well, there are a couple of things that we do know. Well, a lot that we know actually about Alzheimer's and dementia of the Alzheimer's type. And one of the things is that people live 4 to 8 years on the average after diagnosis, but can even live as long as 20 years, depending on many different factors. And so, Jessica has done a lot of research for us today as to the different stages of Alzheimer's. And we have early stage Alzheimer's, which is where we see some of the initial, more mild symptoms, the middle stages, where we see these are some of the symptoms that people have and that they can live with. But with some assistance, mild to moderate assistance, and then late stage where they really do need care. And I think, Jessica, you really wanted to concentrate today on late stage, but certainly we can share some information with all of you on the different stages.
Yeah, so
and
in the early stages of the disease, is where we start to notice the changes. And there's maybe a variety of changes. It may just be a couple of things, but they're significant enough that they're interfering with daily life, right? You're starting to notice that maybe some things aren't possible or may need assistance in order for those things to happen. The middle stage of the disease is where people tend to spend the majority of the time. That can be, like Dr. Jeff said, anywhere up to 8 to 10 or more years. In the middle stages of the disease is where people are going to be needing more assistance with things. Safety becomes more of a concern, and there's a lot of things to think about. That's where caregivers and help might be needed now. When we get to the late stage of the disease, which is usually, a year or two, the later part of the disease progression, that's where we start to see the signs a little bit more obviously that the person is declining. They're no longer able to do the things that they were once able to do. And so when we talk about the late stage of the disease, or you might hear end stage, you might hear the severe stage, we're talking about the point where the disease has progressed to where now a person requires assistance with pretty much all elements of daily life. And we're focusing on that today because it's not something that gets quite as much attention. And it's something that's a little harder to talk about. It's something people don't really like talking about. But because we know it is inevitable, we are going to get there. Dementia is a progressive disease. It's something we need to address. So I wanted to take a few minutes and just talk a little bit about some of the signs of late stage disease. You might see this in the person you care for or care about, but also it's good to be aware that these are the things that are coming, right? These are the things you might watch for. So I mentioned safety. safety is always a top priority. And when somebody is progressing through dementia, there will come a point where they are not able to be left alone safely. They will require 24-hour care and assistance, and we definitely see that in the late stage. You might start to see that there's very limited speech. Maybe they're only able to communicate a few words. Maybe they're not communicating with words at all, or it's kind of that nonsensical babble. Some people will describe it. And they probably aren't understanding what you're saying to them either. The brain is no longer able to process language in that same way. We definitely see people will be sleeping more than they're awake at this stage of the disease. And they have most likely lost a lot of muscle coordination. So, those fine motor skills, being able to do things with their hands, swallowing. There's a tremendous amount of muscles in our throat that are required to swallow safely. So, swallowing, choking, aspiration become a challenge. Also, the muscles that control our bowel and bladder. So you might start to see incontinence of bowel and bladder both. They might not even be able to walk or stand or sit upright without assistance. You'll see weight loss. And you might even see people that are kind of withdrawing from the world around them. Some people talk about, they're living in their own world. And that is something that we definitely see in the late
Is there a
stages.
timeline of this late stage? Is it something that can last for a year or more? Or are we going to see this decline in a week or two or a month?
Yeah, everybody's progression through the disease is different, because it depends on the age they're at when they receive a diagnosis. What other health conditions are they dealing with that could contribute to things, might speed up the progress, or they might be somebody who is very healthy, has worked hard on their health. And things might progress a little bit slower. So everybody is different. Generally speaking, dementia is a progression of about 8 to 10 years. Like Dr. Jeff said, it can go up. I've seen people with Alzheimer's disease live 20, 25 years with the disease. The late stage, though, is typically much shorter. The body is declining, major functions are starting to shut down. And so that usually is somewhere in about a year or two.
Yeah, and the important thing to point out here, Dee, is that when we look at the early and the middle stages, in the early stage, yes, the person usually can get around, do the things they have to do. The memory loss is not as great. They can become confused. They seem to be more absent-minded. But they, usually can get around, do what they have to do. Minimal assistance is needed, but we really should be there as a family and caretakers to provide them whatever they need. The middle stages, as Jessica talked about, now we need a little bit more care or a lot more care, but really working with them around the psychological issues that they're having, the emotional issues that come with this, because they know that they're starting to lose their independence. But when you get to that late stage that Jess has been talking about, yeah, you're seeing not only mental decline, but you're seeing severe physical decline. And so, what does that mean? It means now, unlike the mild and the moderate stages, the early and the middle stages, now at the late stage, you're looking at round the clock care. You're looking at all sorts of medical interventions. At some point, because of this issue of not being able to swallow, forgetting how to swallow, coordinating the muscles and swallowing, you might even start looking at feeding tubes and so on. But here's the thing that is really difficult for families that I've worked with, and Jess, I'm sure that you've seen this too. Just as you think that person is at the end completely and not going to make it, then the cognitive abilities may come back, or the emotion may come back for a couple of hours, or they are sitting up in bed and they're having conversations. They still have a lot, for the most part, 99% of the mental impairment, physical impairment, but they seem like, oh, it looks like they might be coming back. It looks like they're fighting, and they are. And then by that evening or the next day, then they go back almost into some semi vegetative state. So, this is something, Alzheimer's disease, dementia associated with Alzheimer's is so, so difficult for the patient, of course. That's the person who has to live with that. But the families and the caretakers, they're on a roller coaster ride too. And in many ways, we talk about this ambiguous loss, Jess, you wanted me to bring up, where physically they may be there, um, as far as the body is there, but they may be gone emotionally, cognitively. Physical impairment is so severe, they're not getting around. And so we kind of feel like, well, they're alive, but they're really not. And so we have to be careful with this ambiguous loss where we feel that we're no longer connected physically with them, but understand that they are there and talk to someone about it. That is the biggest issue, Dee, that we see, in addition to the suffering of that individual, of course, is that the family and the caretakers giving this round the clock care, going through all of these ups and downs, bathing a person who brought them up, touching them in that way. All of that, if I can use layman's terms, is a mind blower for them. And too often we see that these individuals are not getting their own care. They're not getting rest. They're not getting sleep. They're more prone to colds and, other illnesses and viruses. So it's so important that if you are a caretaker, whether you're hired and being paid, whether you're a family member, whatever the case may be, there are support groups out there. Get your rest. Make sure that there are shifts. Let's get out of the mindset that there's just one responsible child who has to do everything. Everyone has to pitch in and be there for that person who's at, the end stage.
And I think most of us are now becoming more and more aware of the challenges that caregivers face. And I can only imagine the heartache of that, when the family member peps up for a little bit. What causes that pepping up? And, how do you know that this is just a pep up? Because there's no way back from this late stage dementia, right? There's nothing you can do to slow it down at that point.
Right. When we're at the point of late stage dementia, even in the middle stages, right, there's nothing that we're going to be able to do to restore the parts of the brain that are damaged or really are gone, right? Dementia is the result of brain cells that are dying. So there's nothing that we can do to reverse that, to bring it back. There's a lot of things that we can do to focus on quality of life and comfort and maintaining a connection with the person with dementia. This phenomenon that a lot of us in hospice and end of life care see goes by a lot of names. The bloom before the fade, the visit from the angels. There's so many different names that we've given this amazing phenomenon that I'm not sure anybody truly really understands what causes it, right? It can be that burst of energy, that burst of brain activity that can bring a person to wake when they have been unresponsive for days, to suddenly have a conversation and recognize family members that are around. I had a similar experience with my own grandfather, and to this day, I remember it so clearly. And a lot of people see it as a gift, right? Take it for what it is. But like Dr. Jeff said, it can be very stressful too, because now you're wondering, did I do the right thing? Are we really at the end? What's really going on here? So being aware that that can happen, I think is important so that people can just kind of, think about the possibility that this person isn't returning. They aren't suddenly cured. This is part of the normal process of the brain shutting down.
And at the after this conversation, we will post some resources for caregivers to those who have dementia and dementia, Alzheimer's dementia as well. So, how does one actually die from dementia?
This is a question that I would get all the time from families because people often want to know, well, does dementia actually kill you? How does a dementia cause death? Because it's a little unclear. It's not as obvious. With dementia, the changes that are happening are in the brain. You can't see that. I think if we were able to see how the brain was changing and maybe shrinking in size, we might have a little more empathy toward
Mm.
people that are living with dementia and doing the best that they can in spite of those brain changes. When the disease has progressed and now we're getting to those final stages of the disease, what happens is the changes in the brain, combined with the inability to move around as much anymore, will eventually weaken the body to the point where the person becomes really, really vulnerable to infections, to falls, to maybe even other injuries. Pneumonia is actually the most common cause of
Mm.
death for
Right.
people with dementia. And it's really interesting in that a lot of the data we have about the number of people who are living and dying with dementia is not as accurate as it could be because death certificates and records will often list the cause of death as pneumonia rather than the underlying disease of Alzheimer's or another type of dementia. So, with pneumonia, for or really for anybody who spends most of their time in bed, that's something that we see a lot. So the body has become weakened. It's unable to cough, to fight infection in the same way. They're at really high risk of aspirating
Mm.
or breathing in food or liquid. And that's what pneumonia is. It's that fluid in the lungs that leads to a life-threatening infection. If someone is fortunate enough to avoid those infections and avoid pneumonia, eventually it's the destruction of brain cells caused by the dementia progression and the disease that will eventually impact all bodily functions, such as breathing and
I'm sure that this can be very difficult, both on the caregiver, as we've mentioned, but what does a person with late stage dementia experience? Do they have a conscious knowledge of their decline? Are they feeling pain and discomfort?
I think this is a really great question. And it's one of those that we probably will never truly, truly know because we can't really ask them, right? So we watch for those nonverbal signs. Pain, untreated pain in people with dementia is actually a really, really huge problem because
Mm.
at some point, the person with dementia loses that ability to recognize, hey, I've got some aches and pains over here. I think I should take a Tylenol for that. The ability to ask for medications, to kind of think through that and rationally realize that's what's going on and this is what I need to make it better, right? So, untreated pain in people with dementia is a huge issue. So, it's something that we really need to pay attention to as professionals, as clinicians, but also as families because you know that person best. Trust in your gut. If you are looking at them and you are seeing those nonverbal signs of discomfort, maybe they're trying to move around in bed and they're a little, kind of restless or agitated, or the classic kind of what are you seeing on their face? Is their face relaxed? Are you seeing little furrows in their brow that could suggest they're uncomfortable in some way? Let's be proactive. Let's give them Tylenol or Advil or whatever has worked for them in the past. We know that there are aches and pains that we all experience, right? Or if this is somebody who maybe has had migraines their whole life, those don't suddenly go away just because somebody is now in the later stages of dementia. So that's something we definitely want to pay attention to.
And let's not forget, Dee and Jessica, this is the importance of hospice. This is whether at home or in a nursing home or in a hospice care somewhere, a hospice center, palliative care. I can't tell you how many times I hear the providers, whether it's a CNA or whether it's an LPN or RN or NP or physician, saying, "Are you in pain? Are you in pain?" And quite often the person cannot respond, whether it's because they can no longer speak, whether it's because they're oversleeping, whether it's because they may fall into a state of unconsciousness. So they have to, exactly as Jessica's saying, they have to look at how they are breathing. They look at their faces, whether they're grimacing. They're looking at bed sores. So there are different ways that they can find out. But this is really why hospice care and palliative care is so important. I must tell you that there are end of life. We know that there are healthcare disparities in many different populations, including my population, Black Americans, Black and Brown Americans, and so on, right? But we also know that there are end of life um, health disparities. We see too many people of color who have dementia of different types, vascular dementia, Alzheimer's, Lewy body, whatever the case may be. They are dying. They are at the end. They are in some sort of pain, but yet they are still in ICUs, and that's not where they need to be. They need to have hospice and palliative care.
Real quick for all of our viewers, can you give us an overview of the difference between hospice and palliative care?
Yes, thank you for asking this question, because it's a very common misconception, and they do tend to get used interchangeably a lot.
Did I confuse anyone? Did I do that?
Not at all.
Just
So
go ahead and clear it up and talk about the difference and where they overlap, of course.
happy to. So palliative care, palliative is a fancy word for comfort care. Palliative, to palliate symptoms. Palliative care is a special type of care to help basically keep somebody comfortable, whether that is through disease treatments. We see it a lot in cancer patients. They will have palliative care to help manage the symptoms of treatment. But palliative care is really for people of any age at any stage of a disease. It is really effective for people that are living with a long-term chronic serious illness, because it helps manage those symptoms. It helps be proactive, keeping people out of the hospital, managing and supporting a good quality of life. Palliative care is, unfortunately, it's one of those things that it's not always available everywhere. There's a great organization called the Center to Advance Palliative Care that has wonderful resources. And I would definitely recommend taking a look at them or speaking with your physician about where palliative care might be an option for you. Hospice care, on the other hand, is a specialized type of care for people that are in that final phase of life. So it is at the point when someone has been determined to have 6 months or less of life, which is determined by two physicians, that they become eligible for hospice. That can be really tricky, especially for somebody with dementia, because that doesn't follow a normal progression. So what I say to people is, would you be surprised if this person was no longer here 6 months from now? Right? Would you be surprised if they didn't live through the end of the year, let's say? If your answer is yes, it might be time to think about hospice. Hospice is a comprehensive program that provides access to a full team of professionals that are really there to support. They incorporate all the elements of palliative care. So we're focused on symptom and comfort and managing medications, but it's really all about quality of life and honoring that person and their priorities and supporting their family and their network of support around them. Hospice has 24-hour assistance available, not 24-hour care in the home. That's a difference, but 24-hour support. Think of it like a nurse line. So if you have questions in the middle of the night, if somebody's having symptoms, you're not sure what to do, you're going to be able to call hospice and get that guidance. I can't say enough good things about hospice and all the benefits that are available through it. And the earlier you consider it and take advantage of it, the more you'll get out of all of those benefits. One last thing I want to mention about hospice, because when we talk about it, we need to know what it is, but everybody also wants to know how's it paid for, right?
Yeah, very
Hospice
important.
is a benefit that is covered by insurance. Medicare Part A covers the hospice benefit 100%. So everything that is a part of that Medicare hospice benefit is covered 100%. Your Medicare Advantage plan, all your copays, doesn't matter when it comes to hospice, right? Medicaid programs, private insurance also will cover hospice. Those we want to find out a little bit more if it's 100%, but oftentimes it is. And the hospice program can tell you what your coverage benefits are.
That's very important to know. I remember when my husband's uncle was in his last stages of life, he was able to receive hospice care at home. And it was a real comfort both to him and to our other family members as well. Really important service.
Hospice is about allowing a natural death. It is supporting people through that final phase of life and whatever that looks like. Hospice programs bring in that medical aspect of care, but they will also bring in that spiritual, emotional, mental support, as well as just those practical resources. The social workers and the spiritual counselors that are a part of the core hospice team are experts in getting people connected to all the different benefits and resources that they may need. But hospices also have volunteers and other specialty programs. A lot of them will have things like music therapy, pet therapy, massage therapy, and other things like that that can be part of that person's experience as well.
And is hospice just for the person who's dying? Obviously, they provide a comfort for family members and caregivers, but are there additional services that are available for family members of someone who is actively in the stages of passing away?
Yeah, that's one of the most beautiful things about hospice. And unlike anything else that's out there in our healthcare system, hospice is as equally focused on the family and the primary caregivers as they are the person who's actually at the end of life. So, all of those services I described, the social work support, the counseling, all of that is for the family as well, sometimes even more so. Uh, Hospice will also have bereavement support. So after the person passes, your support from hospice does not stop. So there are bereavement programs that every hospice has to be able to provide that ongoing support and assistance as you cope with life after that loss.
That's right. And you can see when people finally are at the stage where their loved one is getting hospice care. Jessica's talking a lot about what happens at home, but even in the hospital, for example, or the nursing home, if they're providing hospice care there or a particular center, you see that they're constantly talking to family members. You will see them, be as they'll capitulate as much as possible. They'll provide them what they need. They bring in chairs for them to sit down. They're very kind to the family members, and that's also very important too.
Yeah.
That is really, really great information. And we're going to share another resource on the screen that Jessica just sent to me, caringinfo.org. Jessica, can you tell me a little bit about what people can find on that resource?
Yeah, caringinfo.org is a wonderful resource full of information about not only life with serious illness, but care at the end of life. So, both palliative and hospice care. The more that you can learn about this before you need it, the better, right? If you wait until that moment when you need it, if you wait until you're in that crisis, it's harder to make decisions and your options are actually fewer. So, Caring Info is a great place to start with information about, hospice, palliative care, things to think about when someone has a serious illness. But also, one of the things that they talk a lot about is advanced directives. And actually, our next session is going to focus on advanced directives because thinking about all of this is important, but talking about it writing it down, making sure the people around you know what your wishes, your values, your priorities are for your care, and doing that in an advance directive is also extremely important.
Absolutely. And when we talk about that, we'll talk about the importance of choosing the right proxy while you can. Who's going to make those decisions for you? And as part of that advance directive, it's not just what you're memorializing on paper, but the conversations that you're having with family members, with loved ones, and with the people who are providing.
This is a very important conversation and one that I'm sure is difficult to both listen to, participate in, and speak about because one way or another, death affects us all. Dr. Jeff, as we close, do you have any mental health recommendations as people are thinking about these difficult topics where they may be able to find support if they are feeling nervous, distressed, worried?
That is a fantastic question, and we deal a lot with that, with compassion and choices, and goes back to what Jessica is talking about. It's about the advanced directives, but it's also about the advanced conversation.
Mhm.
People don't like to talk about death. People don't like to talk about the end of life. And so it's important that, as painful as those conversations you feel that they can be, once you start talking about what you want the end of life to look like for you with your family, those conversations become easier. As a matter of fact, they can become very beautiful conversations because you really are talking about the quality of life, from the beginning right until the end of life. Making sure that if, for example, you are part of some sort of religion, that you have that kind of conversation with your clergy. What does death mean to you? You don't have to be into religion. It's just about the conversations, for example, that you have with your family as to what death means to you. Talking with, having a relationship with your providers. That is so important. Again, we don't see enough of that in the Black and Brown community, where you have a family physician that you can have these discussions with as to what it will look like, what you want it to look like. So don't be afraid about talking, with relation to death. Because if we talk about birth, if we talk about life, if we talk about living, um, death, dying is part of that circle. So begin having those conversations. And again, they don't need to be downers, they can actually be very empowering.
I think that's a really great place to wrap up our conversation for today. And Dr. Jeff, Jessica, thank you again for walking us through this really complex and sensitive subject. And I hope that you all will join us next week for part three, Planning for Life and Death with Dementia, where, among other things, we will be discussing advanced directives. That's going to be on Thursday, September 21st at 11 a.m. Pacific, 2 p.m. Eastern. And in the meantime, go back, watch part one if you haven't seen it again. Watch this one again. Watch it with your family members if this is a situation that you find a family member in right now. And continue to connect with us in the comments. We'd love to know your thoughts, your questions moving forward. Once again, thank you so much for joining us.